Okay, so this is the review for exam 8, your last exam for 1040. I cannot believe how fast the semester went. It's been kind of a crazy one. So, Carolyn, are you ready to go?
Yeah, I'm ready. Okay, so there's actually only 9 questions on my part. Out of the whole thing. So now you can see where you need to study and where you don't. And again, I'm just going to ask you a few things. So remember, when we're talking about different kinds of sexual response cycle, make sure you know that entire thing, how it works. You have the desire, and it goes in where excitement, and then you have plateau, and then you have orgasm, and then you have the refractory. Now remember, the refractory is something that is only men have. Okay, so they're going to ask you questions about refractory and what properties it has. So don't put down that girls and guys get those. No, only the guys have that. That's a period of time where they cannot perform. Okay, and it all depends on how old the person is, what's going on, everything else. So it can be a matter of a minute to a matter of days. Also, all the terms that are there, they're going to use those in the scenarios, so you have to know what they are. And remember what we talked about masturbation. No matter what you might think it is or isn't, it is actually a part of sexual response and a sexual way and normal. Okay. Also, look at the factors that are influencing someone's sexuality. It's just not your DNA, right? It's also how you feel about yourself, how you look, all those types of things that will influence how you perceive yourself sexually. And then there are some different communication styles. It hits really big on the how to take a sexual history. Remember, in the book, I showed you, and there's also a link on Canvas that tells you how to do a sexual history. And when you're doing the sexual history, you got to look at your atmosphere. You're not going to be doing it in front of the nurse's desk with everybody around. You're going to be in a private place, hopefully just you and the person, and so that they can feel that they're comfortable, and it's going to be confidential. Also, you don't do yes and no questions. You start with generalities and you bring it in. Okay, so the same kind of thing. So if you were looking at different age groups that you're going to talk to, and specifically if you had like adolescents that you were working with, how are you going to communicate with them? So we know with adolescents, you have to be honest and you have to be consistent. You can't be up and down in all those places, or they're not going to believe what you're doing or what you're saying. Then also the types of people that you would do a sexual history on. Remember, not everybody who comes in, they're not coming in for sexual issues, but some of the other things will interfere or cause sexual problems. Remember the medications, your psych medications that have a real big issue, your hypertensives that have a big issue. So somebody comes in because their high blood pressure is up. They also need to be aware that they may have some side effects of this. If they do, please get a hold of them, or you'll end up with people who are too embarrassed to tell the doctor that it's interfering with their sexual activity, and they'll stop taking their blood pressure medication and end up with a stroke. Okay? Have actually a relative who did that. Also, people who have diabetes, it's going to affect them. People who have different body parts removed, they have a colostomy, anything that's going to change how they perceive themselves as a sexual person is going to actually influence whether you want to really go in and do a sexual history. Again, the sexual history, you're going to do it and you can incorporate it right into your assessment. people who have heart attacks, who have things where they can't have overexertion for a certain period of time, that there's a rehab period of time. So they're going to have to change what's going on, okay, so that they don't end up having a heart attack while they're in the middle of intimate contact with their spouse or something. So those are the main things that are going to be touched on this. There are other ones on the final, but these are the main ones that we're going to talk about. Okay, so it kind of overgeneralizes, does pretty much everything we had on the test. So does that help you guys? No, I don't have any comments.
Sounds good.
Yeah, and if when you're studying and you have questions about the stuff that I talked about, hey, just text me and I can text you back if you're confused about something. But pretty much in a nutshell, those are the things that they're going to be talking about. Okay, so if you don't know the terms and they use that stuff, you're going to go, crap, I don't know what on earth they're talking or what is that. Okay. So I'll go ahead and let Natasha finish, and we'll see you. And good luck. I want everybody to do a fantastic job on this test.
Yeah, nothing would make us happier. Thanks so much,
Yes.
Carolyn.
Okay, thanks. Bye-bye.
Bye. All right, so let's move on to the next unit. That was Unit 16, Human Psychology. Hi, sorry about that. Can you guys hear me? Okay, I don't know what happened. It might have been my cat who's really bad. I'm gonna throw him out downstairs. Okay. So, and that all got recorded. Sorry for that little, I don't know what happened, but I threw my cat down the stairs, so hopefully if that was the problem, it won't happen again. Okay, so let's look at the Unit 17, which is STIs, and I've got the STI table, and really everything you need to know pretty much is on this. This table. I'm just going to go over, highlight a few of the things that you want to pay a special attention to. So, and we'll just do it disease by disease. And again, I mentioned that you don't need to worry about memorizing the incubation time periods. So with chlamydia, be aware of the OB implications are that the baby can be exposed during the birth process and it would cause conjunctivitis. So we routinely give prophylactic ophthalmic ointment to protect them from getting conjunctivitis associated with chlamydia, and then all equally we give the ophthalmic ointment prophylactically for in order to prevent the eye complications associated with birth from when they have gonorrhea, which the problem with gonorrhea is it can cause ophthalmia neonatorum, which can cause blindness. We treat women who have chlamydia, or, sorry, not and, but or. So the doxycycline, it needs to have be dosed for a full week, whereas azithromycin is a single dose medication. And while we're talking about medications, and remember, gonorrhea and chlamydia are very similar in that they have similar complications, similar symptoms in both male and female, and the leading cause of pelvic inflammatory disease, or PID, is chlamydia. All right, so we treat, and if you remember too, gonorrhea is the STI that is becoming increasingly resistant to antibiotics. So we treat it with, it's only susceptible to the third generation cephalosporin, which is ceftriaxone, brand name Rocephin, and we give it combined with azithromycin, and that is to help augment the ceftriaxone to help diminish increasing resistance to it. So you just need to be familiar with the signs and symptoms of chlamydia and gonorrhea are urethritis, mucopurulent discharge in the females, and let's see, abnormal menses with gonorrhea. Okay, that's it for those two. Next, we move on to syphilis. Remember, syphilis is the one that has the four stages. The first, and you need to keep straight which stage has which symptoms. All right, so the first stage, or primary stage of syphilis, there's the painless chancre at the site of infection, where the microbe was introduced to the person. And the second stage is they get that syphilitic rash and also flu-like symptoms. Third phase is the latent phase. There's no symptoms. And then the tertiary is the fourth stage. And that's when it goes kind of systemic, and it can cause gumas and heart and central nervous system damage. That one is treated with penicillin. It's the same medication we've been treating it with since the 1940s. All right, trichomoniasis. This is the one that is the protozoa, and it has a foul, frothy green discharge, and it causes the cervix to take on a bright red appearance, which we call strawberry cervix. Herpes, it also causes an ulceration. Like syphilis, it does cause an ulceration. However, with syphilis, it's painless, and with herpes, it is painful. So that's the major difference there. Herpes also, the initial outbreak also causes flu-like symptoms. And so in those two respects, herpes is similar to syphilis. Other than that, it's quite different. Obviously, herpes is a virus, whereas syphilis is a bacteria. Herpes, once it's acquired, it's a lifelong infection because there's not a cure, but there is a manner of treating the symptoms to alleviate the discomfort associated with the symptoms. Outbreaks occur after times of stress or when the immune system is compromised, like at times of illness. So it's related to the herpes. There's two types of herpes simplex virus, type 1 and type 2. They are related but different strains. Type 2 is more serious, and it is they can both cross over. So originally, type 1 was considered the oral, non-sexually acquired herpes, and then type 2 was the genital herpes, which was sexually acquired. But because of oral sex, now we see both strains in both areas of the body. Let's see, if a woman has active herpes lesions at the time she goes into labor, if a pregnant woman has active herpes when she goes into labor, she will need to be delivered. She will need to have a surgery, C-section, to deliver the baby. And as this says, the treatment just alleviates symptoms and does not cure. Human papillomavirus is associated with many different types of cancer, and it has a vaccination called Gardasil, which will help to prevent any cancers that are caused by HPV. It also causes genital warts. Yeah, there it is. I was looking for that. Okay. And then hepatitis B vaccine is the last STI we'll talk about. And its symptoms are more GI related and also color related. So by that I mean when there's liver damage, instead of the bilirubin getting excreted through the stool, it is excreted through the skin and the kidneys. So because of that, the stools become a lighter color and the skin becomes jaundiced and the urine becomes a darker color. So those are those symptoms indicated there that are associated with color being off. And then the GI symptoms are loss of appetite, nausea and vomiting, fatigue, headache, and malaise. We now give hepatitis B vaccinations to all newborns, ideally within 24 hours of birth. However, if the mother has hepatitis or is positive for the hepatitis surface antigen, then that baby would be given HBIG. Maybe did that not show up here? Can't read it, it's too small. But anyway, it is on your chart. The baby is given the hepatitis B immunoglobulin, and also should be vaccinated with the vaccination, HPV vaccination, as soon as possible. Okay, let's move on to the next unit, which is the biggest unit, and that is the reproductive disorders. So I'm not going to go line by line on this. I'm just going to hit on the key areas to focus on, starting with PID, pelvic inflammatory disease. It causes, the symptoms are lower abdominal pain, fever, nausea and vomiting, dyspareunia, and a complication of PID is it can cause the fallopian tubes to scar, which would cause infertility and ectopic pregnancy. Toxic shock syndrome is associated with tampon use. If it's left in place, if tampons are left in place too long, it allows Staph aureus to grow in the tampon and spread to the woman and causes systemic illness, which is very serious. So we just teach to avoid that, leaving the tampons in too long. Structural support disorders are caused by aging because of the loss of estrogen, which increases muscle tone, and it's often a delayed, because it's associated with aging, and it's often seen as a delayed side effect of childbirth, because traumatic childbirth can weaken the pelvic floor. and then ways to help decrease, to prevent or at least diminish the severity of structural support disorders are to do Kegel exercises. We teach women not to smoke because smoking, a smoker's cough can aggravate the or further weaken the pelvic floor, and also to obtain an ideal weight and avoid constipation so there's not more weight that the pelvic floor muscles have to support. The cystocele is when the bladder is prolapsing into the vagina, and the rectocele is when the rectum is prolapsing into the vagina, and those both cause pelvic pressure. Cystocele can cause stress incontinence and urinary tract infections, while the rectocele has bowel symptoms, as you can imagine, fecal incontinence, hemorrhoids, and constipation. And then the vaginal fistula, which is an opening between the vagina and a neighboring organ. For example, if there's an opening between the bladder and the vagina, then there would be leakage of the urine coming out through the vagina. And if there's a fistula between the vagina and the rectum, then there would be stool coming out of the vagina. So it depends on what the organ or area that fistula is connecting to the vagina. You'll have different symptoms. And then when there's a prolapsed uterus, that there's 3 degrees of prolapse, and the 3rd degree is the most severe, and it's when the uterus is actually protrudes fully outside of the body. So the uterus is visible outside of the body. The treatment for cystocele and rectocele is a colporrhaphy, and if both are done at the same time, we call it an A and P repair, anterior and posterior repair. Remember that polycystic ovary syndrome is a problem that's associated with insulin resistance, because insulin resistance, hyperinsulinemia causes increased androgen in the ovaries, and that increased androgen causes the virilization of these women, where they have a greater problem with acne, hirsutism, which is facial hair growth, and male pattern baldness. And so to treat that, there's 2 types of treatments, medications that are given. First is metformin. This is a hypoglycemic agent, and that is to decrease the hyperinsulinemia that contributes to the hyperandrogenism. And then the other treatment is hormones. Let's see. Again, I'm having a hard time reading that. I have it listed there. Anyway, oh yeah, it's there. Hormones. And the type of hormone they get depends on whether or not they're trying to have a baby or get pregnant. So, but typically, most women are not actively trying to get pregnant. So, in that case, we would give oral contraceptives. Okay, next slide. Mastitis is most often, like over 90% of the time, it's caused by clogged milk ducts in women who are breastfeeding, and it will cause painful area on the breast, and it's usually very, very tender and reddened. So like a wedge section of the breast will be reddened and inflamed, and it would, on palpation, feel hard to the touch because of the clogged milk duct. There's milk backed up in that mammary gland, and so that feels very firm. And also these women have flu-like symptoms. And it's treated with analgesics, antibiotics, and teaching women to empty the breast fully when they breastfeed. Next, we'll talk about breast cancer. So this is one that one of the many female gynecologic cancers that is associated with caused by increased estrogen exposure in a woman. So that means that nulliparous women who've never given birth, or if they had their first pregnancy after age 25. Also women who are older. We don't see it as much in younger women unless there's a strong history of BRCA-related cancers in the family. And then smoking also increases the risk of breast cancer. Women who have had a mastectomy, we try to prevent problems with lymphedema by avoiding doing needle sticks in the affected arm. So let's say she had a right mastectomy, we would not want to do needle sticks on the right arm. We also, as much as possible, avoid taking blood pressures in the affected arm. However, some women have a double mastectomy. In that case, it is okay to take a blood pressure in the arm, but we just try not to over pump or get it tighter than it really needs to be. And we also teach women to avoid carrying a purse or a handbag on the affected arm because that would interfere with lymph drainage. And it helps to use gravity. So we teach her while she's at rest to elevate her arm, and while the collateral lymph circulation is being developed. And exercise also helps to develop that collateral lymph circulation. So we do promote exercise and elevating the arm and preventing any strictures or anything that would compress or decrease circulation in the arm. All right, for uterine cancer, there is a very obvious symptom of that, which is abnormal uterine bleeding. So and it's most commonly seen in postmenopausal women. Younger women don't tend to suffer from uterine cancer, but we still want to see women if they have abnormal bleeding, no matter what their age is. You guys don't need to know the rule of twos, but if for women who are not, at least not for this exam, but for women who are not yet menopausal, if they're having abnormal bleeding, it would be defined as last menstruation that lasts more than 2 weeks or more than 2 cycles in a month. But that's not something you're going to be tested on. What you do need to know for the test is abnormal uterine bleeding in postmenopausal women is the biggest symptom, and it gets women in to be seen. And so usually we catch it early and can treat it, and it has a pretty good survival rate. Which is not the case for ovarian cancer. Usually we don't detect it until it's more advanced. It is a very quickly spreading, quickly growing cancer. So there's not, and I didn't really emphasize this very much when I was covering this, but you do need to know that there is not an effective screening tool for ovarian cancer. And the reason for that is because it has a super high, they have tried a screening tool, which has a very high false positive. 90% of the positives are false positives. And also, since it grows so quickly, they calculated they would need to screen every 3 to 6 months in order to be effective in catching it and detecting it while still in the early stages. So for those 2 reasons, the high false positive rate and the super frequent 3 to 6 months screening timeframe, which just is not really realistic. For that reason, there is not a good screening test. However, there is a good diagnostic tool. So once a woman does come in with thinking that she might have ovarian cancer because she has those very vague signs and symptoms, remember the vague signs and symptoms are bloating, eating less and feeling fuller. This is the BEAT acronym. Abdominal pain and trouble with the bladder. So if she has more than 12 of those vague symptoms in a month, she needs to come forward to a gynecologist and say specifically, I'm concerned I might have ovarian cancer. And then they would do a diagnostic tool, which is an ovarian biopsy. And that is very effective. The diagnostic tool is effective, but there's not an effective screening tool. So make sure you've got those two bits of information very straight in your head for this exam. So risk factors for ovarian cancer are, again, increased exposure to estrogen. So age, nulliparous woman, a woman who's never been pregnant. Also, having the BRCA gene is associated with not only breast cancer, but also ovarian cancer. And then if you also need to know what decreases the risk of ovarian cancer. And these are things that protect a woman against ovarian cancer, which are to have her ovaries removed, which some women with the BRCA gene just do that prophylactically to prevent getting ovarian cancer. Having a tubal ligation, because it's believed that sometimes the cancer migrates from the uterus out towards the ovaries. So ligating those tubes, fallopian tubes, will help protect the ovaries. And also breastfeeding, it diminishes the number of times a woman ovulates, as does pregnancy. That's why pregnancy and breastfeeding both are protective against ovarian cancer, because it gives the ovaries a rest, because every time a woman ovulates, it's a little bit damaging to the ovaries, and the more times she ovulates in her lifetime, the more her risk for ovarian cancer. And yeah, and I mentioned pregnancy and childbirth help to decrease the risk. Okay, this is the gynecological cancer that has the highest mortality rate, and that is most likely due to the fact that it is very rarely, relatively rarely detected while it's still in its early stages. Okay, cervical cancer is caused almost probably 99% of the time by HPV. Okay, next slide. Well, let's see. We'll talk next about infertility. So it's important to know that things that contribute to infertility in men are testosterone supplements, because remember, testosterone needs to create sperm. The testosterone needs to be in the testicles. And if there's an elevated testosterone level in the circulating blood, then the testicles get the biofeedback loop, tells the testicles they don't need any to produce more testosterone, and so that decreases fertility in men. Also, having a warm environment in the scrotum, which can be caused by like varicocele or hot tubs, or wearing tight jeans, clothing that doesn't breathe. Those all contribute to male infertility. And then things that contribute to female infertility are, of course, our PID, endometriosis, and for both male and female, smoking and alcohol and substance use increase the risk of infertility. Diagnostic treatments, there are several. I'll just mention the two of them. Hysterosalpingogram is the exam that they inject radiopaque dye into the uterus, and that comes out the fallopian tubes. They do an X-ray to visualize to see if the dye is exiting the fallopian tubes. Then they know the tubes are patent, and it also helps to clear the tubes temporarily, so it increases the chance of pregnancy for a couple of cycles after it's done. And then the postcoital exam is done at the time of ovulation, and it's checking for evidence of to see how well the vaginal cervical mucosa promotes sperm motility and vitality. So if, for example, a postcoital test is done and it's the sperm are detected, but they are all dead, then there's a good likelihood that a woman has an autoimmune disorder that it has where her body has killed the sperm, and that does happen. Contrast that with they do a postcoital and the sperm are thriving in the woman's cervical mucus, then they know that that's not the issue and they have to look for other things. Okay. And then just remember that the ART therapy, which is assisted reproductive technology, has the two that are being done in the United States now are the top two, in vitro fertilization and intracytoplasmic sperm injection. So remember, in vitro fertilization is when they harvest the egg and they combine it in with the sperm in a petri dish. That's the in vitro fertilization, and then they place it into the uterus. And then with intracytoplasmic sperm injection, that's where they take a single egg and a single sperm, and they kind of take a needle-like object to penetrate the egg and inject the sperm directly into the egg. And of course, they would make sure that they've got a healthy ovum and a healthy sperm to do that with. And then once the egg is fertilized, they can place that into the uterus. Remember that there are, we have to pay attention to whether the treatment will work depending on whether or not the woman's tubes are patent, like for intrauterine insemination, which is also called artificial insemination. The woman has to have patent fallopian tubes for artificial or intrauterine insemination to work. If her tubes are blocked, the ovary is not going to be able to get to the uterus to meet up with the sperm there. So, however, these two therapies are compatible with a woman who has blocked fallopian tubes because both of them bypass the fallopian tubes because the eggs are extracted directly from the ovaries, put in a petri dish where fertilization occurs, and then placed into the fertilized egg is placed into the uterus. So it totally bypasses the ovary tubes. Okay. Endometriosis, this increases the risk of infertility. It is treated effectively with oral contraception, and then discomforts are treated with non-steroidal anti-inflammatories like ibuprofen. PMS, remember that one is associated with the second half of the menstrual cycle, which is the luteal phase. And so the woman will be symptomatic for a week or two prior to when she starts her period. And these symptoms, there's two types, physical and emotional. PMDD is a more severe case of PMS where the woman's symptoms are debilitating to her ability to function in life, with whether it's work or school or relationships. Okay, really pay attention to this box here, highlight it so you know how we can treat or minimize PMS and PMDD. We can treat it with SSRIs. And a healthy lifestyle is very beneficial, including good exercise and good diet. Diet is really important. There's a lot of information here. Don't smoke. That's technically not diet, but that's important to know too. And then limit refined sugars, salt, alcohol, and caffeine consumption. Eat whole grains, lean protein, nuts, vegetables, and the type of vegetables that are the most helpful are the cruciferous vegetables. That's your broccoli, Brussels sprouts, cauliflower, and cabbage, because those help to process the estrogen metabolize the estrogen in a way that minimizes symptoms. And calcium just helps with PMS. Doesn't really help too much with PMDD. Okay, next slide. Menopause. Remember the difference between perimenopause and menopause. If a woman is listing her symptoms, which are depression, hot flashes, difficulty sleeping, anxiety, dyspareunia, and irregular menses, I'm going to take a poll. Yes, she's in menopause, or no, she's in perimenopause. Okay, some of you are still thinking about it, but I'm going to publish the poll and move on. And about 2/3 of you got it right, and the other third missed the fact that I said one of the symptoms is irregular menses. So if she has irregular menses, she's not yet menopausal, because remember the definition of menopause is that it's been a year since her last menstrual cycle. So if you see irregular menses along with these other symptoms, you know she's still just perimenopausal. So pay attention to that detail. Women need to continue to use birth control until it's been a year since their last menstrual cycle, because they are still fertile until we define that they are menopausal. Perimenopausal women are potentially fertile. Okay, so they can have a really late in life pregnancy. I could take another poll, but I won't. Mostly, well, I will just for the fun of it. Yes or no? I know of a woman who had a late in life pregnancy. And these are coming in a lot fast. These responses are coming in a lot faster, and almost all of them are positive. Again, I'll just quickly publish. So yeah, like 3/4 of you guys who voted know someone who had that late in life pregnancy. So it sometimes it's even planned, but a lot of times it's not. Okay. So let's talk about hormone replacement therapy. You guys really need to know this. Know this very well. Know both the pros and the cons of hormone replacement therapy. It's a little bit complicated, so you really need to study this to keep it straight. Okay, so the pros are it has hormone replacement therapy has an excellent success rate. Almost 100% success rate and I shouldn't say almost, essentially a 100% success rate in eliminating hot flashes. And it also decreases the perimenopausal related emotional things going on, like depression, insomnia, anxiety, I said insomnia. Anyway, so it's very good at eliminating those, or at least significantly decreasing those symptoms. However, in addition to relieving those perimenopausal symptoms, it also decreases the risk of colon cancer and the risk for fractures. Because remember in our lecture yesterday, we talked about osteoporosis, and the risk for osteoporosis goes way up when a woman is menopausal, because when she loses her estrogen, that allows her body to decrease her the bone mineral density to decrease. So those are really great things for hormone replacement therapy, effectively relieving the discomforts associated with perimenopause and menopause, decreasing the risk for bone cancer, not bone cancer, decreasing the risk for osteoporosis, and then decreasing the risk for colon cancer. So it's beneficial to the bowels, the bones, and what's another B we can call it? The bowels, the bones, and the boobs, the women associated. Anyway, no, it doesn't benefit the boobs because it does increase the risk for breast cancer. So that doesn't work. Anyway, so the bowels and the bones, it helps. It doesn't help the boobs because one of the risks is it increases the risk for breast and uterine cancer. So keep that in mind. Cardiovascular disease is also increased, even even though estrogen helps to protect against cardiovascular disease, the Women's Health Initiative study showed that it increases the risk for stroke and myocardial infarctions. However, that is felt because most doctors feel like that is because in that study they were giving it to women who were really too old to be placed on hormone replacement therapy. So hormone replacement therapy needs to be given early on, during perimenopause and early menopause. And it should not be given like in the 60s, when a woman's in her 60s or 70s, mid to late 40s through mid 50s-ish. Okay, so that's a lot of information, but you will appreciate knowing that when you sit down to take the test. Okay, male structural disorders. Remember, the varicocele is associated with, that's the varicose veins of the scrotum, and it is associated with infertility because it overwarms the scrotum and the testes. And let's see, torsion is when the gonads, the male gonads, the testes, get twisted, and it causes excruciating pain. And it also is at risk for causing infertility if it's not treated immediately. So it requires immediate surgical detorsion. Okay, benign prostatic hyperplasia. That's when there's the slow, the prostate kind of chokes off the flow of the urine through the urethra, because the prostate gland wraps around the urethra. And as it grows, it continues to grow slowly throughout the man's lifetime. So 75% of men over 70 will have this. And it causes slow urination, difficulty starting and stopping a stream, dribbling, and complete bladder emptying. And it's treated with a TURP, which is a transurethral resection of the prostate. And it is also treated with aquablation, where the water, jet water spray widens the opening to the prostate. And those are followed up with like an irrigation to flush it out. Prostate cancer, it has a it's very slow growing, so it has a high 5-year survival rate. We do not routinely screen every man anymore, just because there is a high overdiagnosis when you screen every man, which means that they would treat men with potentially harmful side effects from the treatment, such as erectile dysfunction, whose disease, who would never really suffer seriously from prostate cancer if it weren't for having done the screening. So we don't want to do overdiagnosis. However, African American males have a much higher incidence of prostate cancer, so they are when the doctor is weighing the risk-benefit ratio and helping them to do the combined informed decision-making process, they will more likely encourage an African American to have this screening done because of their increased risk of prostate cancer. Men can decrease their risk of prostate cancer with healthy diet, exercise, and keeping an optimal weight. Let's see, if screening is to be done, the test that is done is a rectal exam and also a PSA, which is prostate-specific antigen. And if those come back positive, then they would do a diagnostic test, which is a prostate biopsy. And treatments for prostate cancer are testosterone suppressing medications and also doing a radical prostatectomy. And the last one we'll talk about before we get to birth control is risks of therapy, which are right here. I kind of, let's see, risk of low testosterone. So for a while, it was really popular to, men would go in seeking testosterone therapy just because it naturally, the level goes down as the men age, and so they kind of miss those higher testosterone levels. And so a lot of men went and said, hey, I would like some testosterone therapy. And so a lot of men were placed on testosterone replacement therapy, and then they started seeing more DVTs, and there's the concern of greater risk for cardiovascular disease, which there's, like I said, the jury is still out on that. They haven't confirmed that it absolutely causes increased risk for cardiovascular disease, but it is concerning enough that they're trying to decrease the number of men who they place on testosterone therapy and just be more judicious in deciding who can go on it. Once it is diagnosed, testosterone levels are checked before the diagnosis is made. Obviously, they need to know if they actually have low testosterone before they place them on testosterone therapy. So we check the testosterone levels before, as a diagnosis, before they start the therapy. And then once the therapy starts, the levels need to be checked every 6 to 12 months. So they really don't need to test them extremely frequently. It's not like they need to test them every week or every month, even every month. Even just once a year is adequate. So just that's a little detail I didn't mention when I was going over this in the unit, but I remember that's something that you guys need to know for the test. And also, it's often administered as a gel or a patch, and men need to be told to place the gel or the patch in an area where other people aren't going to touch it, and therefore have the testosterone hormone transfer to, say, their wife and their kids. Okay. Last page of this table, and that is the contraception page. What you need to know about this is the special instructions and then the non-contraceptive benefits. And I think the type of method is pretty obvious. Like, we know that abstinence and lactational amenorrhea are natural methods. We know that the condom and the cervical cap and spermicides are barrier methods. Anything that has estrogen or progestin in it are the hormonal methods. Then the IUD is technically that's a LARC, long-acting reversible contraception. And then sterilization is the tubal ligation and the vasectomy. And then we've got our emergency contraception and abortion. So those, I think, are pretty obvious, so I'm not going to spend any more time talking about the types of methods. But I will just highlight on the special instructions that you really need to know. For the diaphragm, remember that it needs to be inspected before each use to make sure that it is still intact. So they just hold it up to the light and see if they can see any light coming through it, and then they know that if there is no light coming through it, they know it is still intact and safe to use. And also remember that diaphragms and cervical caps must be used with spermicides in order to be effective. And one more thing to remember about that is with the diaphragm, it must be left in at least 6 hours after sex to make sure that it is effective. And similarly, the cervical cap needs to be left in 8 hours. And it also needs to be used with spermicide. Moving down the same column, looking at the pill, you need to remember that it is what the contraindications are, especially that women with a risk for thromboembolic disorders must not be given oral contraception, because that it will increase their risk of developing blood clots. However, these women with thromboembolic disorders can take the mini pill, which is the progestin-only pill. Let's see, the intrauterine device, it lasts, depending on the type, because remember there's the copper one and there's also the one that's embedded with progestin. Depending on the type, it can last anywhere from 5 to 10 years, and the copper one lasts longer. Women also need to periodically check to make sure that the string that's attached to it is in place, so that they know that it's still in place, and they say to check it about every month or so. Tubal ligation and any sterilization, tubal ligation, or vasectomy are considered a permanent method of birth control, not reversible. Men who have a vasectomy need to be taught to use an alternate type of birth control for 1 to 2, well, to be on the safe side, 2 full months after a vasectomy, because it takes about that long for the sperm to be purged from their system. And they should also have a negative sperm count to verify sterility before they have unprotected sex. And then now let's talk about non-contraceptive benefits. The biggest one here is, of course, condoms can help prevent against STI. And the oral contraception has a lot of non-contraceptive benefits in treating female reproductive disorders such as dysmenorrhea, endometriosis, premenstrual syndrome, and premenstrual dysphoric disorder, also polycystic ovaries, and any type of ovaries are going to diminish, not ovaries, cysts in the ovaries. The cysts in the ovaries will diminish in size and number when a woman is placed on oral contraception. And it also decreases the risk for, remember, the colon cancer and uterine cancer and ovarian cancer. So it's got a lot of great benefits. And the IUD can be used as a form of emergency contraception if it is placed within 7 days of unprotected sex. And then just one last thing to mention is elective abortions. The method used depends wholly on the age of the gestational age, or the length of the pregnancy. So we can't really help a woman decide what can be done to treat her if she wants to terminate her pregnancy until we find out how the length of the pregnancy. All right, that is it. Oh, it looks like that took just like exactly 1 hour. I do not have sample test questions for you. I realized this morning that I left the test banks of the sample NCLEX questions on my office desk, and remember this is my day off, so I decided not to run in on my day off to grab it. So I thought you guys would be okay just with the review without the sample questions. I know those are helpful, but I didn't do the heroic thing and went in and grab it to create that for you. Are you guys good with just the review? And like Carolyn said, if you have any questions as you're studying, feel free to text me. Okay, great. Thank you so much for that feedback. That makes me feel better for not having created a sample quiz for you. But have a great rest of your weekend. I'm going to see some of you tomorrow at clinical, and those I know everybody has clinical, so have a great week in clinical. And you guys are getting so close, and you're doing so well. So have a nice weekend, and we'll see you next week. Bye.